Today we will be covering the schizophrenias, which are a group of common major psychosis with a complex syndromal presentation, meaning that it is like a final common pathway, like in hypoglycemia, which can be due to a variety of causes, affecting young adults, showing chronic changes in behavior, perception, thoughts, and emotions, causing a fundamental disorganization in personality and deterioration from previous levels of functioning. Now, looking at the epidemiology of schizophrenia, which is quite a common condition affecting the population, uh, one very interesting characteristic is that it's a universal disease found in all countries at all times, and even much more uh, unique is that it is almost constant prevalence rates whichever country. There are some exceptions, but overall we'll find that it's almost the same wherever in the world we go, and the clinical presentation also has very similar features. The incidence is roughly about 15 to 20 per 100,000 per year. That is the new instances of schizophrenia that happens, that manifests. Prevalence is around 0.5 to 1%. So in the population, we find about 0.5 to 1% having the illness at any time. Normal risk, that is when we look at the whole lifetime of a person, there is a risk of 0.7 to 1.3, or we say usually 1%. Now, we said earlier that schizophrenia is found in all countries, and it is fairly the same prevalence rate, about 1%. But there are some exceptions. Um, in some cultures and in some countries, we find that there is a higher incidence, and in some there are low incidence. So when we look at certain cultures, there is a higher incidence. For example, in northern Sweden, in Western Ireland, Catholics in Canada, and unfortunately Tamils both in South India and Sri Lanka. And we were able to establish this in our study, which we did in 1993 with Professor Ganeshwaran, Dr. Yoganathan, and myself. So what we found was when we calculated the incidence, it was around 34.6 per 100,000. And as I mentioned, some countries have low incidence. For example, the Anabaptist section of in the United States. Other characteristic features of schizophrenia is that it affects a very young population, the youth and early adulthood, around 15 to 45 years. The sex ratio is about equal, but there is an early onset in males. So females tend to get it a little later, and there is some evidence that female hormones, uh, particularly progesterone and estrogen, may be uh, in a way protective. Now, there's been a lot of research, and it's very important also, particularly from a preventive point of view, and also to understand the illness, to try and find the etiology. And so far, what evidence shows that it is multifactorial, many causes which may combine in different ways to produce the illness. So what we say is that there's a genetic component and there may be an environmental component, and presentation, manifestation may differ. So you get a kind of a, uh, uh, a phenotypic expression that can vary depending on the combination of factors. So the hereditary aspect, the genetic component has been well established. There have been uh, quite a few family studies. It's been very clearly established that schizophrenia runs in families, and the more the genetic relationship, the higher the risk. So that evidence has been very clearly established. Um, for example, 40% of the patients usually have a family history. And in our study in Jaffna that we mentioned earlier, we found 63% have a family history, and that may give a clue why there is a higher incidence in among the Tamils, because there's a uh, 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 familial interbreeding, or people tend to get married within the family or the extended family. The cousins get married and so on, and that may be one of the reasons that it is much more prevalent in some cultures. So one of the strongest evidence for the genetic component is that when we look at the relationship, if both parents have the illness, the risk is 46%. So definitely the uh, risk is high. If only one parent has schizophrenia, then we find that the likelihood of them, a child developing the illness, is 15%. While if both parents have schizophrenia, then the child is very likely or highly likely to develop schizophrenia. um, the risk if another sibling, the brother or sister, has the illness is again the same as having one parent. So that is quite uh, logical. The risk is about 10 to 14% of them have the illness. Now in monozygotic twins, that is twins where they have the same genetic material, the same genes, the risk is, or the incidence is 42%. 42%. So if one twin develops illness, the risk in the other twin is around four, or the chance that the other twin will develop the illness is 42%. So it's almost like having both parents. While if it's dizygotic twins, where the genetic uh, similarity is like having a sibling, the risk drops to the same as for a sibling. So this clearly shows the genetic loading, how important genes are when the genes are the same. But it does also clearly show that environment is also important, because if the genes were the only etiological factor involved, if it's a completely purely genetic illness, we would expect, for example, if the monozygotic twins, 100%. If one twin develop the illness, the other twin should invariably develop it. So it shows that environmental factors are also important. So there's an interplay between the genetic and the environmental factors in causing schizophrenia. When we look at second degree relations, cousins and so on, and extended family, the risk is a little higher than in the normal population, which is, as we mentioned, around 1%. But in the second degree relation, the risk, the incidence is about 2 to 3%, double. So still, showing a genetic component is important. And there has been quite a lot of research into the possible genetic uh, genes involved, and one uh, uh, possible candidate is so-called the COMT gene, the gene that is responsible for catechol O-methyltransferase, which is involved in the dopamine catabolism, has been identified as a possible genetic marker. And this also is uh, goes with the theory, the dopamine theory. The dopamine is involved in schizophrenia. It is a neurotransmitter that is predominantly implicated in schizophrenia. Now, that is the genetic uh, component, and uh, we find that that's very important, but also environmental factors are as important. Uh, and we find that uh, conditions in the family, that is not the genetic component, but how the family functions. For example, in the relationships between the different members, the parents, the mother, how they communicate with each other. This has been also researched, and they have found that there may be um, various ways of uh, communicating, or the relationships that are very strongly emotional, something sometimes termed expressed emotions, amount of uh, emotion involved in the relationship. When it's very strong emotions, that may predispose. Um, Another um, uh, factor that has been identified is something called double bind messages, where uh, it is said that parents, or particularly the mother, may give uh, contradictory messages to the child as the child grows up. So the child doesn't know which is uh, the true, or what the really the mother wants. So it's caught in what is called a double bind. The mother, uh, say, asks the child to kiss her before going to bed, but shows through her body language or from uh, previous uh, occurrences that she doesn't really want the child to. But if the child doesn't kiss the mother before going to bed, then the mother may blame the child, saying the child doesn't love her or some. So the child is sort of grows up in this kind of where is not sure what the mother is trying to say, or is caught in what they call double bind. And of course, the mother has been blamed. Of course, this has not been established, and there's now a lot of evidence that shows that the mother is not. But there was a time when they believed that the mother, schizophrenic mother, they say, the way the mother communicates and relates to the child. So the one of the ways that they study the emotional content or the emotional relationship is this concept called expressed emotion, which we will have mentioned sometime later also. But it is composed of looking at the hostility. They're always critical and finding fault and uh, fighting. Uh, it's a kind of relationship which the child finds hostile, or the parents or the relations may be very critical of the child, all the time finding fault, or the mother may be over involved, always uh, trying to uh, intrude into the life of the child. Whenever the child is trying to do something, or even trying to be alone, or going and lying on bed, the mother may go and uh, disturb the child, saying, "Why are you doing this? Why are you doing that? Why don't you do this?" Always involved in the life of the child. Now, other environmental factors that have been identified is one is viral infections. For example, um, children born during certain uh, periods, for example, in Western countries during the winter, where there's a higher incidence of virus, viral infection of the mother, there is this theory that the child may be getting infected in utero. Um, Then birth trauma has been clearly shown to be, so. People who develop schizophrenia, if you look at their birth history, there's a higher incidence of birth trauma. So possibly various injuries during birth. Endocrine factors have been clearly implicated. I mentioned about uh, females, their hormonal uh, hormones, the sex hormones may be protective to some extent, and they have shown that there's a higher incidence following partners when there's a precipitated drop in the levels of estrogen and progesterone, and that may be a factor involved in the high incidence of psychotic illness, schizophrenia-like illness following uh, delivery, labor, postpartum, and the later onset in females, as I mentioned. Um, another uh, endocrine factor may be thyroid, hyperthyroid madness, myxedema madness. So uh, the endocrinal organs may be involved, the hormones that are secreted. Stress has been clearly shown to be so a stressful life event or a stressful period that a person goes through, adolescence, exams, um, love relationships, um, even trauma, post traumatic stress disorder. These seem to bring out a kind of psychotic illness, sometimes called reactive psychosis or psychotic reaction, where they may manifest with schizophrenia like symptoms, hallucinations, and delusions. But usually, prognosis is good when the stress is removed or when the period of stress is over. They may recover and they may usually make a full recovery. So, the prognosis is usually good when only stress is involved. But if they have also a genetic loading, they have a family history, and they are vulnerable in other ways, it may bring out the whole illness. Uh, so, um, trauma and migration. There's a condition even labeled migration psychosis, going to a new environment where they don't may not have social support, and they are under pressure to adapt to a new culture, the so-called culture shock. Person may become very paranoid and suspicious, and they develop a kind of something called migration psychosis. And various physical diseases like encephalitis, pyrexia of unknown origin, antimalarial therapy, post surgery, various conditions where there is a physical insult to the body, where there is a strong physical injury to the functioning of the body, the person may develop psychotic illness. Another factor that's been clearly uh, found to uh, bring out an illness in some people is sensory loss, particularly hearing loss. In the elderly, sometimes called late paraphrenia, when as they age, they lose their hearing, or even at an early age, when they can't hear what other people are saying, they may become suspicious and paranoid, and that may evolve into a kind of paranoid schizophrenia, paranoid psychosis. Head injury, and that's been also clearly, particularly after the head injury during the post trauma period, post head injury, they may develop. Epilepsy has been clearly shown to be involved in a uh, later development of psychosis, sometimes called epileptic psychosis. Quite a high, quite a substantial number of individuals with epilepsy develop a kind of psychotic illness later on. So, after having the epilepsy for a period, they may then start showing signs, symptoms of psychotic nature, and usually the epilepsy improves. The number of seizures or epileptic fits uh, actually decrease, while psychotic illness becomes much more severe. And it's very interesting if they have a seizure or if their seizure control is temporarily or for some reason lost and they have a full-blown seizure, they may show some improvement. So that is one of the uh, uh, features of ECT treatment also. Some patients improve with ECT. So even a seizure or in a epileptic patient who has epileptic psychosis may sometimes show a temporary improvement in their condition. uh, Drugs, particularly amphetamine, which is a drug that involves a dopamine pathway. Uh, Clearly, they develop a kind of paranoid psychosis, schizophrenia, if, after abusing uh, amphetamines, methamphetamine, and drugs of abuse. Even the drugs used in for ADHD is one complication which we have to be careful and watch for. Drugs used in Parkinson's disease, because again it may be involved in the dopamine system, um, are well known to produce schizophrenia like illness, very similar. Cannabis also can produce something called a cannabis psychosis. Person can develop a schizophrenia like illness, psychotic illness. Multi-system connective tissue disorders like SLE, systemic lupus erythematosus, you can get a psychotic manifestation. Um, Socio-cultural factors, um, for example, it's quite clear that people in the lower socio-economic classes are much more, schizophrenia incidence is much higher in people who belong to, and it's not very clear whether that itself is the cause or people with schizophrenia tend to become unemployed, single, and drift into a lower social class. Um, and some populations, if you do various surveys, people who are homeless, prostitutes, in the prison population, you find that there's a higher incidence of schizophrenia. So again, this is whether it's etiological or whether it's a drift. People with the illness then tend to go into these kind of situations. They become homeless, or they get involved in they break the law because of their behavior, and then they end up in prison. So quite a high percentage of people in prisons now, particularly in Western countries, that they have closed many of the long stay institutions, the insane asylums of older age all of past, maybe over the last few decades. There has been an increase in the prison population. Many of people who have been uh, sent home then end up doing very minor crimes, or they may be found to be causing a nuisance in public, and they may be arrested. So these populations also you may find a higher incidence. And of course, as I mentioned, the single and the unemployed, there's a higher people with schizophrenia tend higher uh, number who are single and who are not able to work. They lose their job or they are not able to hold down a job. So whether it's a cause or the drift, because of the illness, they drift into these situations. Now, when we talk about the etiology, uh, these are socio-cultural and genetic factors and so on. But what is the final common pathway? How does it finally manifest in the body? If you look at it uh, in a microscopic or uh, at a biochemical level, and what they have identified is that some neurotransmitters are implicated, have a uh, role in the development of schizophrenia. And the strongest candidate so far, and the most amount of evidence, is that dopamine is the culprit. um, One obvious evidence is the drugs, the medications and the drugs used in schizophrenia, or the ones that cause schizophrenia, like illness, like amphetamine and so on, all uh, have an impact on the dopamine pathway in the brain, particularly in the mesolimbic pathways. There are different dopamine pathways which we will cover in a short time. Um, the mesolimbic pathways may be involved with uh, hyperactivity, the dopamine activity, and some of the drugs that are effective in treating schizophrenia block, so they are dopamine blockers. There may be also some hypofunction in the mesocortical pathways, which will come to, which are more the cause of the negative symptoms, while the hyperactivity may be the causing the positive symptoms in schizophrenia, which we'll also come to into later. Uh, but the dopamine hypothesis has been found not to be sufficient. It doesn't explain everything in schizophrenia. There's a long delay in the work in the benefit after using drugs, and uh, various research using neuroimaging and other postpartum studies and so on have not established dopamine as the sole. So other uh, neurotransmitters may be involved, and one strong candidate is glutamate. Uh, the and they have found that some receptors, the NMDA receptor, the N-methyl D aspartate receptors, they are maybe hypofunction, and they may be linked in some way to the dopamine pathways also, the balance. Similarly, serotonin has also been identified, and some drugs particularly work on the serotonin system. Now, looking at the dopamine pathways in the brain, there are several dopamine pathways. In fact, they have identified about five. Here we have actually made them into letters, so A, B, uh, C, D, and E. And uh, depending on the origin and where the pathway ends, the first one that is very important is the nigrostriatal pathway, starting with the substantia nigra and ending up in the striatum, the various nuclei there. And this is very important in, as you know, in Parkinson's disease and other conditions. In schizophrenia, the importance comes because when we use drugs that block the dopamine pathways, particularly drugs that are broad, that block all the different pathways, the one of the important side effects that we see in many of the patients, particularly the older generation, uh, is extrapyramidal symptoms, just like Parkinson's. They may mimic Parkinson's disease, pseudo-Parkinsonian side effects. So that is the first pathway, and that may be important because of the side effects. Then we have the second pathway, which we call the uh, mesolimbic pathway, going to something in the limbic area called the nucleus accumbens, and this may be involved in regulating behavior, the pleasure that people are said to derive from various drug abuse, and also in schizophrenia, the positive symptoms of delusions and hallucinations may be result of hyperactivity in this pathway. So when we use drugs blocking these receptors or this pathway, that may be the benefit and the improvement in the positive symptoms, particularly the older generation of antipsychotics. But they have also found another pathway uh, going to the cortex. One is to the dorsolateral prefrontal cortex and to the ventromedial prefrontal cortex. And these pathways may be involved in the negative symptoms of schizophrenia. Um, the uh, dorsolateral prefrontal cortex is said to be involved in some of the cognitive symptoms, negative cognitive functioning, and so on. And uh, uh, the ventromedial prefrontal cortex may be involved in the affective, the emotional disturbances that we find. And some of the newer atypical antipsychotics may help, or is claimed that they help in alleviating these kind of negative symptoms. Then we have the tubero-infundibular pathway from the hypothalamus to the anterior pituitary, and this is involved in the release of prolactin. So one of the side effects of using dopamine blocking drugs is that this uh, prolactin secretion may become dysregulated, and you may get an increase in prolactin secretion. And that is one way of studying the monitoring, uh, seeing uh, the effect of the use of antipsychotics, and what effect the atypicals may not be so, particularly drugs like aripiprazole may not cause increase in prolactin, but some of the other drugs are, they can cause quite a high increase, 3000, 4000 levels. And then there is another pathway that has been identified in the dopamine system, which is not very clear what its function is, and it is starts from various multiple sites in the uh, midbrain area and goes to various nuclei, including the thalamus and hypothalamus and various other, and it's not very clear what function it has. So, trying to um, uh, summarize what we have been saying about the various pathways and the effect that it has in schizophrenia, trying to understand the symptoms based on the anatomy. Um, this is from Dahl, the psychopharmacology book by Dahl, illustrated, and it shows in pictures, in images, what we have been saying. So, um, the mesolimbic pathway may be involved in the positive symptoms, um, the one that goes to the nucleus accumbens, and this is what we, by blocking due to the hyperactivity, you get the positive symptoms. So by blocking it, you can relieve the positive symptoms. Then the mesocortical pathways uh, to the dorsolateral prefrontal cortex may be involved in the cognitive symptoms, and the pathway to the ventromedial prefrontal cortex may be involved in the affective symptoms. So, treating this is much more difficult, and usual drugs that we use in schizophrenia do not have much effect on the negative symptoms. It's claimed some of the newer atypicals have a more effective in changing some of the negative symptoms. The nigrostriatal pathway is important because of the side effects, particularly the typical antipsychotics that we used. They invariably produce some kind of uh, nigrostriatal uh, uh, dysfunction, particularly extrapyramidal side effects. And the tubero-infernal pathway resulting when we use drugs. So when we are not using drugs, when a person may be having schizophrenia, that is untreated schizophrenia, you might find that these are normal. But then when you start the person on drugs, you get the extrapyramidal side effects due to blockage there, and rise in prolactin. So putting this all together, uh, they have come up with something called a neurodevelopmental theory, which says that uh, the negative, some of the symptoms, the impairments that have been found, particularly in the prefrontal area, some of the neurological soft signs that have been found, people may be a little incoordinated, may not be able to carry out complex motor tasks, uh, maybe due to some developmental as a person grows up. Maybe there's a genetic basis. So they have shown, they have done some neuroimaging studies and shown that certain areas of the brain, particularly the frontal lobe, there is some decrease in the functioning. So um, this is the hypothesis that is laid down in early life, the neurodevelopmental insult, and that it can cause some damage in the particularly in the prefrontal areas. So this is the kind of putting various factors here. The genetic predisposition, the genes are very important. Maybe up to even half the vulnerability in the person is due to genetic, but they can be also environmental factors, which we mentioned, various stresses and so on, which together may produce the neurodevelopmental changes or abnormalities. And these manifest as cognitive and social impairments and some soft signs. And the final common pathway for uh, these kind of etiological factors is dopamine and abnormalities in other neurotransmitters that finally manifests as schizophrenia. So this is a very complex illness, and there may be multiple factors involved. It's not all established clearly, but this is the current understanding. Now, symptoms of schizophrenia have much more recently been um, explained or have been categorized into positive and negative symptoms. This is uh, little different from the way that it was understood earlier, where they used to divide schizophrenia into simple schizophrenia, catatonic, hebephrenic, paranoid, depending on the symptom profile. This division into positive and negative is much more uh, helpful in understanding the course and the treatment in management uh, to target. So there are drugs that are particularly effective against positive symptoms like hallucinations, illusions, and so on, and not so effective against the negative symptoms, which may need much more rehabilitative measures, environmental manipulations, and gradual process of activation, so that various negative symptoms like apathy and the four A's, so called apathy, amotivation, evolution, and socialization, can be addressed. And of course, the disorganization in thoughts and emotions that is so uh, uh, characteristic of schizophrenia, full-blown schizophrenia, the florid schizophrenia, is something that is very difficult to treat at the start. So these are kind of pictorial, again from Dahl, illustrated uh, the different types of symptoms that schizophrenia presents with, and sometimes the treatment can be directed. So, for example, the drugs may be directed at the positive symptoms. The negative symptoms may sometimes respond to some of the atypicals, but usually you need rehabilitation and other measures to improve it. And these can be then divided into affective symptoms, aggressive and cognitive symptoms. The aggressive symptoms sometimes need very strong tranquilizers, like some of the strong benzodiazepines or even the antipsychotics with a higher sedative profile. All the chlorpromazine, haloperidol, uh, quetiapine, olanzapine. These are drugs that can be used when the patient becomes aggressive. Behavior is disturbed. So this is another pictorial representation of the picture that we get in schizophrenia when they manifest with the symptoms. So again, it's the same thing like the last one, but put in a slightly different way. So we have the positive symptoms, um, which are quite obvious and you can see them uh, quite clearly. Hallucinations, delusions, aggressive behavior, and the negative symptoms, which may become manifest only later on, and which are much more difficult to treat, and they are cause long-term impairment in functioning, particularly social functioning, family functioning, and so on. So the positive symptoms are the delusions and hallucinations, and they may be very assaultive or abusive. Affective, the emotional disturbances are like depression, suicidality, and loss of interest. Um, Cognitive symptoms affect attention, impaired executive functioning. They are not able to carry out or plan. Um, and so together they produce a kind of picture of reduced speech, lack of emotions, and apathy, kind of withdrawal, and they lose their motivation and drive, which are devastating, particularly in a young individual who should be very productive, working, uh, very involved in family life, in the society. They sort of withdraw and become not involved. So that is the implications of schizophrenia, particularly from a public mental health point of view and long-term management. So this is sort of artistic view of or drawings from a schizophrenia showing that disturbance in thought patterns. So one of the characteristic symptom in schizophrenia is thought disorder, where they get loosening of association and derailment and various manifested thought block and so on, and the thinking becomes disorganized. So this is a table showing some of the frequency of symptoms of schizophrenia, and this can vary. Different people, it can be, and it can vary even based on the culture. Some may be more prominent in some cultures, but generally, most schizophrenia patients don't have insight. They don't realize they have an illness. They may uh, believe uh, that there's nothing wrong with them. Auditory hallucinations, particularly in third person, is very characteristic. And you can get it in up to 74%. So it's worth looking for auditory hallucination. A lot of psychiatrists ask person as a part of a routine mental state examination whether they do experience any auditory hallucination. The easy way of establishing schizophrenia. Ideas of reference, delusion of reference is a little more severe form and maybe a little less common. Paranoid ideas, uh, uh, flatness or blunting of effect, uh, delusional mood, and delusional perceptions. These are a little more difficult to establish, uh, but delusional perception is a first rank symptom of schizophrenia. So these are also characteristic. So when we want to diagnose schizophrenia, um, Traditionally, they have used the first rank symptoms of Schneider, uh, which have to be present in the absence of organic disease. So, if they have some uh, organic brain pathology, then that takes precedence. That is the diagnosis. But in the absence of any organic, obvious organic pathology, like a brain tumor or uh, some kind of dementing process or uh, infection, these first rank symptoms are diagnostic of schizophrenia. The most easy and maybe more common is auditory hallucinations, third person, thought insertion, withdrawal, and broadcasting. Maybe a little more difficult to establish, but it's again characteristic. Delusional perception is also sometimes called a primary delusion. Passivity, when the person feels that they are being controlled or that others are making them feel things or do things and so on. Somatic hallucinations. So these kind of symptoms were used classically to diagnose schizophrenia. But the trend has now moved a little more uh, broader, and both the ICD-11 and the DSM-5 uh, generally look at delusions, hallucinations as a category, and also look at the functioning, the change in functioning capacity, the deterioration in functioning. They give much more importance to that nowadays. Now, differential diagnosis is very important in schizophrenia, and of course, uh, very important from the management point of view also. So, it's always worth asking about history of epilepsy, um, particularly any seizures, uh, any history of childhood seizures, and so on, cerebrovascular diseases, cerebral neoplasm. So, as I mentioned, any organic disease of the brain that is fairly gross, obvious pathology in the brain can cause symptoms mimicking schizophrenia. Even some widespread infection of the brain, AIDS, uh, particularly when the brain is involved at some stage. Later on, it produces a dementia, like as we mentioned in a previous lecture. Um, Substances, particularly amphetamine, has been uh, clearly implicated in schizophrenia-like illness. But other hallucinogens and alcohol alcohol can produce a paranoid psychosis in later chronic use. Now, these are some of the medical uh, differential diagnosis. Then we have some so-called psychiatric differential diagnosis, where other psychiatric diseases may resemble or may mimic schizophrenia. So already I mentioned about brief reactive psychosis, where there is a strong stress factor, acute presentation, but with a good prognosis. So once the stress is removed or they cope with the stress, like a trauma or a migration, they recover. They make a full recovery. Schizoaffective disorder, where there are mood symptoms, affective symptoms, depression usually, or it sometimes can be manic, and the picture can vary from one to the other, or it can both present at the same time. You can get a condition called schizoaffective disorder. Then affective disorders, particularly mania, can be misdiagnosed as schizophrenia. Delusional disorders, where you may not get hallucinations, you may not get so much deterioration in functioning, and it usually delusional disorder you may get it in later life. possession states. So these are subcultural uh, behavioral something that you find in some cultures, and they should not be diagnosed as schizophrenia. Yeah, they may behave in a very odd and bizarre way, or they may believe that they are under the control uh, of some other spirit or some other being possesses them. So you might think it's some type of passivity, but it's a subcultural phenomena, and it should not be diagnosed as schizophrenia or psychiatric condition. Various personality disorders, particularly the schizoid personalities, uh, where you get a kind of autistic loneness and the person withdraws from society, um, may mimic gradual insidious onset of schizophrenia. Obsessive compulsive disorder, where they have very strong images and intrusion of thoughts, sometimes of uh, delusional intensity, sometimes this gets misdiagnosed. So that also you have to be very careful. Comorbidity. So very often schizophrenia, uh, particularly when the initial onset or during the course of the illness, quite a high percentage develop depression, maybe around 25%. So that is something we have to look for, and sometimes it needs treatment on its own. Obsessive compulsive symptoms may be part of the schizophrenia. Anxiety again, and substance abuse, so-called dual diagnosis or dual uh, conditions. Uh, many, particularly in Western countries, we find that many chronic schizophrenia patients uh, use alcohol or other drugs, and sometimes the drug dealers target keep persons with mental illness as somebody easier to get them to uh, buy the drugs and use, make them into dependent people. Right. Finally, we come to the management of schizophrenia, which is quite a difficult uh, condition to treat, and it takes quite a lot of the time and effort of mental uh, health work. And we generally put it under what we call a biopsychosocial approach. That is, we target all this. It's an integrated person has to be seen as a whole, but it may be helpful to understand it, looking at these different components. So the bio component will be mainly the drug management using various drugs, mm, other physical like electroconvulsive treatment or uh, other physical methods, psychological management. Um, some psychological treatments have been found to have some benefit, particularly working with the family, and very important is rehabilitation. Particularly in chronic schizophrenia, negative symptoms, the whole rehabilitation process, which may take months or years, is very important part of the management. So initially, the pharmacological management may be needed to control the symptoms, particularly positive symptoms, the behavioral disturbance, and so on. But then the rehabilitation. So um, that is a very important part of the whole management, and then working with the family, because ultimately the family may be involved in managing, particularly in a third world country. um, the family family looks after the person with schizophrenia, so we have to work with them to educate them, uh, to communicate, give them information about the medication, the importance of regular use, of the side effects, and how to tolerate some of the behaviors of a person with schizophrenia, how to keep him active. So, in the rehabilitation, they become co therapists. So, they can be part of the process of recovery. Now, there's a lot of emphasis on recovery, And teaching is that schizophrenia, person with schizophrenia can recover. I'll come to that later in the prognosis. And if the rehabilitation and the pharmacological management is done uh, thoroughly, we can expect the person to recover. So the family should be encouraged to carry out the rehabilitation process at home. So the pharmacological management uh, is mainly using the antipsychotics, and we have had the typical antipsychotics from the 1950s, which were very effective, made a dramatic change in the whole management of uh, schizophrenia. Asylums uh, were closed. People were then discharged into the community. That's all mainly due to the antipsychotics that came on the market. And famous drugs, quite old but very effective. Chlorpromazine, trifloperazine, peveperazine, haloperidol are the main drugs. For a time, pymazide was there. It's no longer in use. Droperidol is sometimes used in acute management. But the mainstay, and they still continue to be effective, can be used. Chlorpromazine, trifloperazine, and haloperidol. They still have a space, although they produce quite a bit of side effects, the extrapyramidal side effects, and that is the reason that the atypical antipsychotics are now being used. They don't produce so much of the side effects, particularly extrapyramidal side effects that were produced by the typical antipsychotics. So we have drugs like olanzapine, very effective, uh, risperidone, quetiapine, and also amisulfide. It's quite effective. Unfortunately, some of these drugs produce what we call a metabolic syndrome. They may put on weight, get diabetes, heart disease, and so on. So they have to be also monitored, and these drugs also have side effects. The drugs like ziprasidone and aripiprazole, which are partial antagonists of dopamine, do not produce these kind of metabolic side effects. So they may be preferred in that sense, and they have a role to play in the treatment of schizophrenia. Clozapine is a very effective drug. Unfortunately, it has sometimes fatal side complications, particularly blood system, granulocytosis, and so on. So, but if it's used uh, cautiously with close monitoring of the blood levels, and if the indications are very clear, it's very effective. So clozapine has also made a dramatic change, particularly in the prognosis in drug-resistant schizophrenia, which where they are not responding to the other medications. Clozapine works. So, as I mentioned, selection of drugs depends on various factors. In a third world country like ours, um, the availability is controlled by the cost factor. Um, then we have to look at the side effect profile. So, if they are causing a lot of extrapyramidal side effects, then we go for the atypicals. Symptom profile. So, there are a lot of positive symptoms, aggressive behavioral disturbance, we may use the more sedative drugs like chlorpromazine or quetiapine or even olanzapine. Then the person may be having some sensitivity to some other drugs. So again, we look at the specific contraindication. People who have been using a particular drug and they're familiar with the drug may prefer to stay in that on that, and then of course the cost. So what can be provided through